Hello, everybody. I'm Antonio Artigas from Barcelona, Spain. I'm an intensivist and a member of the Global Sepsis Alliance Committee and the Executive Committee of the European Sepsis Alliance. I'm the chairman of the EduSepsis Network, and I am very pleased to moderate this session. This, I think, is a very interesting session on therapeutic advances for sepsis with a specific focus on age and gender and the specific management aspects. And we have excellent speakers, and I would like to introduce the first speaker, that is Marlies Ostermann. Marlies is professor of intensive care and nephrology at the Guy's and St. Thomas Hospital in London. He is always an expert on nephrology, on critical care nephrology, sepsis, and extracorporeal organ support in critical patients. She is the president-elected of the European Sepsis Intensive Care Society and director of the research of the Intensive Care Society in UK, and co-chair the KDIGO ACI guideline. So, Marlies, it's time for you to present your talk.
Thank you, Antonio, for the very kind introduction, and thank you to the experts and the organizing committee for inviting me to speak. I hope you can see the slides.
Yes.
Okay, perfect. So in the next 10 minutes, I aim to convince you that sepsis is different between men and women, and there are various explanations. I have no conflicts related to this talk. But I want to just start by saying there's obviously a difference between sex and gender. So sex is essentially determined by our genes, by the sex hormones, sex chromosomes, and gender is a socially constructed framework. Gender depends on how we are being perceived and how we see ourselves in the society. In the literature, including the medical literature, gender and sex are often conflated, but they are different. So our sex is determined by biological factors, as listed here on your left, and gender is determined by many sociocultural factors, and gender is therefore also is determined by the way we act in the society, by our the ability to take risks, by our general behavior, and that may determine the risk of contracting certain illnesses, including sepsis. I'm trying to convince you that there are differences, and clearly I need to start with the sex chromosomes. So as you know, and as we all know, women and men have different sex chromosomes. It turns out that in women, most genes on the second X chromosome are actually inactivated. But there are differences between different women, and in some women, up to 10% of the X genes on the second chromosome may still be active. And obviously, men have a Y chromosome, and so that means they possess genes that females don't have. So there's already a clear explanation why there may be differences. One of the challenges in this field is that experimental work is often conducted in male animals, in particular male rats and male mice. And so what we know from the pathophysiology from experimental studies, we have to say is limited to male animals, and that's a huge problem. Secondly, it's not surprising that there may be differences because there are obviously also anatomical differences between men and women. Some are obvious, but it's also important to highlight that organs that are not immediately different, like the lungs or the kidneys or the heart, when it comes down to the details, there are huge differences. There are differences in the size of the organs, differences in the cellular construct, and also in the size and number of mitochondria. And finally, as I've already alluded to, there are obviously sex hormones, and they differ between women and men. And within each sex, they differ depending on age. So we have these dynamic changes when we talk about sex hormones. We're very familiar with them, with these changes with regards to changes in women. But it's also clear that men experience dynamic changes in their testosterone levels, and they change over time, as shown here. And this is important because sex hormones, estrogen, testosterone, they affect and influence the inflammatory response following an insult, including sepsis. They affect the neurovascular modulation, immunomodulation following an infection, and they affect and sometimes have contradictory effects when it comes to mitochondrial activity and oxidative stress. And therefore, this is one of the reasons why the response to sepsis differs in men and in women. When we look at the epidemiological data, then this is also shown in many studies where they looked at large registry data or observational studies. And there are differences in the response to an infection between men and women, and there are differences in outcomes. Now, the tricky part is obviously that a lot of these data are confounded by factors related to gender, by factors, for instance, related to risk behavior, to behaviors with regards to drugs and alcohol, with regards to smoking. And so it's not easy to tease out the effect, these differences directly related to sex and not affected by gender. But it appears there are quite a lot of influences directly related to the differences in sexes. And what I just said about sepsis has also been confirmed when we look at ARDS data. There are differences between men and women. There are differences with regards to cardiac outcomes after an MI, also after cardiac arrest. The tricky part, again, being that behavioral circumstances, environmental circumstances, risk behavior, and also behavior to seek medical attention differ between those two sexes. Then importantly, even things like the aftermath of sepsis, like delirium, for instance, we can see differences. And whether this is really directly related to the underlying genetic and sex hormone characteristics, or whether it's related to the way we as doctors treat patients, or whether it's related to the therapy we give to them, is unknown at the moment. Now, the literature is confounded further by the fact that the data are not always conclusive. And so if you, for instance, look at the outcome of sepsis-associated AKI, then some studies suggest that females have an advantage, and other studies suggest that men are more protected. So the literature is quite confusing, but again, confounded by issues related to gender. What I think is very important, and there's increasing data now, and that I think matters again to clinicians as we look after patients, is there is increasing evidence that women and men respond differently to particular therapies. And that's due to that we have differences in drug metabolism. So for instance, there are differences in the body volumes. And this may simply affect the volume of distribution of various drugs and the availability of drugs in patients. There are also differences, physiological differences in the ability to absorb drugs in the GI tract. There are differences in the amount of gastric juice, there are differences in the thickness of the gut, and this clearly affects absorption. And there are differences in protein binding. And at the same time, none of us dose drugs differently when it comes to male or female patients. We may dose them differently in different ages, but not based on sex. And it is possible that this may need to be done in future. And lastly, even drugs that are based on or rely on hepatic clearance have clearly shown huge differences in metabolism between men and women. So I'm coming to the end of this talk. I want to highlight there are so many reasons why we may see differences in the susceptibilities to sepsis and also the outcome of sepsis between men and women. And it challenges, obviously, the fact that this confounding by socio-cultural factors, the willingness, the threshold to seek medical attention, but also the way we as doctors treat patients. And it is possible that we treat them differently in certain countries. That's for sure been well recognized. And it is possible that some of the medications as we give them are inappropriately dosed or too high or too little in one or the other sex. And then finally, what's completely unknown is what about others? What about transgender patients? What about people who take medications, hormone replacement? What about people who take puberty blockers? And this has opened a completely new can of worms because we don't really understand this. So I think having been made aware of this, it has reminded me that we need to do much more in this field, but also as we conduct research and conduct trials, spend more time, i.e., for instance, making sure that we identify the sex properly, that we potentially analyze studies according to sex, analyze whether, when we do drug trials, analyze whether they respond differently in different sexes. And with that, I've come to the end. I hope I've been able to convince you that this is an important area where we have so many gaps in our understanding, where we need to do more work to make sure that we, as doctors, don't disadvantage one or the other sex by the way we treat them, by the drugs we administer. Thank you very much for your attention.
Thank you very much, Marlies, for your excellent presentation. I have a quick question to you. Is the consequences at long term, according to the sex, are different from physical point of view or from the immunological point of view, probably?
Yeah, possibly. There are good reasons why there may be differences in outcome based on immunological reasons, because there are differences in activation of various inflammatory cells. But at the same time, the willingness, the threshold to seek medical attention differs between the sexes. The approach to women versus men in certain countries differs. So it's very hard to compare these data from these large databases because of these confounding factors, sociocultural factors.
But in the new randomized controlled trials, do you recommend to have an equal distribution among sex to demonstrate the benefit of a new treatment?
I'm not sure about that, but I think to start with, I would first of all recommend that we make sure we truly document the sex rather than gender, but we document whether people are taking hormone replacement or not, but we document whether they were pre or post-menopausal. All these things matter, and that we then, independent of the samples, that analyze them differently. So we may recruit 1,000 patients, but then look at the effect of a particular strategy and really look at whether we're men or women or those on hormone replacement also respond differently. And this detailed work has not been done properly. And as I've already said, often in clinical trials, gender and sex gets conflated. I have never seen a trial where they reported transgender or the various different sexes really accurately.
Okay, so thank you very much, Marlies. And I think now we need to move for the next presentation that will be done by Professor Bertrand Guidet. He is the past director of the medical intensive care service at the Hospital Saint-Antoine in Paris, and is a university medical professor since 1997. He is a member of the research unit at the INSERM, and he is the past medical director of the University of Hospital in East Paris, and past president of the French Society of Intensive Care. And Bertrand Guidet is an expert on elderly patients, and he was participated in many initiatives through the European Sepsis, through the European Intensive Care Society. And Bertrand will present not the sex, but the specificities of sepsis in the elderly critical care patient. That is another population that many times are not included in the studies. So Bertrand, it's your time.
Thank you very much, Antonio. Hello, everybody. So I will talk about sepsis in all patients. When you get older, the chance of developing sepsis increase, and the case fatality rate also increase. We duplicate the same results with a database from Paris area, and you can see here that the incidence of sepsis increased with time, and then it decreased a little bit after 80, probably related to admission criteria that might explain that all patients with sepsis are no more admitted in intensive care. The second information is that when you add comorbidities, the incidence might be quite high even in younger patients. So in a way, all patients are like younger patients with comorbidities. And also, when you look at the mortality in ICU, the mortality increases with age, but when you add comorbidities, the mortality also increases for patients younger than 65. When you look at the multivariate analysis explaining ICU mortality, you can see that age has a profound impact, also the severity, the comorbidities, when you have a septic shock, respiratory failure, kidney failure, and when the infection is related to a urinary tract infection, the mortality is much lower. When you look at the cost is very high for neonates and very young children, and it increases in old patients. But when you look at the mean cost per patient, it decreases after 75 or 80, probably again because all patients with sepsis are denied ICU admission. In this study, they duplicate the same, that is, there is an increase, but then a decrease after 80, and probably related to admission criteria, but the cost is increasing with age because you have more patients with sepsis with an old population. This is a French study looking at the incidence of admission for sepsis in all patients, and you see that it's increasing over time. And when you looked at COPD here, or community-acquired pneumonia, it's increased in the different time periods, but it's increased mostly for all patients, that is for patients above 80, above 85, or even above 90. We looked at the impact of age and sepsis. So we used the data from the VIP1 study. Among those patients, some of them had sepsis and some of them had no sepsis. All the patients had a SOFA score above 2. So we made a matched cohort study, and when you compare patients without sepsis and patients with sepsis, they're a bit different. The patients with sepsis are less often mechanically ventilated, but receive much often vasoactive drugs. SOFA score is similar among the two groups. And when you look at the mortality, when you look at the number of patients with limitation or withholding of life-sustaining treatment, it is very similar in both groups. And when you look at mortality, in ICU mortality, 30-day mortality, they are very similar. So it means that when you compare patients all over 80, whether the admission reason is sepsis or is not sepsis-related, the mortality is similar. So the mortality is higher for patients above 80 compared to younger patients. But among the patients over 80, mortality is similar, whether you have a sepsis or you don't have a sepsis. In this very nice review that was authored by Antonio as last authors, you can see that infection is a leading cause of ICU admission. This is true for very young children, but this is true also for all patients. And when you looked at mortality, the contribution of infection is huge, and this contribution is even more important among old patients. And more importantly, when you have a sepsis, there are long-term consequences of an ICU admission. In this study, they have baseline characteristics of the patient. They looked at baseline limitation, no limitation, mild to moderate, and severe limitation. They assessed limitation with activity of daily living and instrumental activity of daily living. And in this study, when you compare before sepsis and after sepsis, there is a great deal of changes after sepsis. And when your baseline is mild to moderate limitation, after sepsis, it's even much worse. And in this study, the follow-up was 5 years after the sepsis. And you can see that the changes does not really improve over time after 5 years. So it means that sepsis is a real insult for the patient, a stress. And when you're old, it's difficult to recover after such an aggression. So I told you there are more sepsis among old patients. There are several factors that could account for this high incidence of sepsis. In the next talk, you'll have something about immunosenescence and inflammation, and for sure this contributes to the risk of sepsis, but also impairment of local immunity, like in the lung, poor nutritional status and sarcopenia, frailty, comorbidities, low physiological reserve, institutionalization and medical devices, resistant strains, because the patients are living in nursing home, they receive previous antibiotic courses, and also they might have atypical presentation, so that might delay the diagnosis of sepsis. This is presented here in this cartoon, and an old patient with sepsis might present with dizziness, falls, dehydration, heart rhythm acceleration, decline in functional status, no fever, and incontinence. So we have to look at those signs that might be sepsis. And we know that old patients have more comorbidities for the heart, for the lung, and more diabetes. Also, the signs of sepsis are different. Among all patients that have more respiratory tract infection, more urinary tract infection, and that might account also for the severity of sepsis in this age population. And just to finish, I'd like to emphasize in this model of sepsis, it's in mice. And when you look at IL-6 production, when you compare 5 months mice and 24 months mice, the IL-6 production is much higher in old mice compared to younger mice. And when you look at the survivor curves, the same insults, that is cecal ligation and puncture, the mortality is much more higher in older mice compared to younger mice. So in conclusion, incidence of sepsis increases with age. It has a higher severity with a higher mortality rate, with different infected sites, more lung, more urinary tract. Beware of atypical presentation that might delay the diagnosis of sepsis. The geriatric conditions contribute to the severity, so you need to assess the baseline geriatric condition, and you need to look at the frailty scale. And when you have a sepsis and when you are old, there are long-term impact on qualitative outcomes. Thank you for your attention.
Thank you, Bertrand, for your excellent presentation. I have two quick questions to you. The first question is that do we need to include patients, elderly septic patients, in the prospective randomized control trial? Because in many studies, these patients are excluded.
You're absolutely right. When you look at the big trials looking at mean arterial pressure in septic patients, when you looked at sedation, weaning technique, etc., all patients with sepsis are usually underrepresented or sometimes excluded from the trials. So it's a problem because we extrapolate to old patients results obtained with a younger population. So you're absolutely right. We need to include those patients in the trials. It could be either a stratified inclusion, but certainly, since we have to deal more and more with old patients, we need to include those patients in the trials.
And also to try to personalize more the treatments in this kind of patients?
Absolutely.
Okay, so thank you very much, Bertrand. and in order to keep on time our session, I would like to just to introduce the next speaker. Next speaker is Adrian Ceccato. Adrian Ceccato is a pneumologist and an expert in translational research. He's working in the Institute of Research at the Sabadell Hospital, and is an expert on immune response and especially in pulmonary infections. So Adrian will present a talk on immunosuppression in sepsis that I think it's an important area of interest. So Adrian, it's your time now.
Thank you very much. Thanks for the introduction, and thank you for inviting me to participate in this very important Congress. I will talk to you about sepsis-related immunosuppression. First of all, I have no conflict of interest to declare. I'd like to start with the sepsis definition. I know that you must hear about this, but I like to repeat. Sepsis is defined as a life-threatening organ dysfunction caused by a dysregulated host response to infection. Here, the key word is dysregulated. So patients with sepsis are not able to coordinate an appropriate immune response. So sepsis is not just a consequence of pro-inflammatory cytokine storm, it's also the inflammatory and anti-inflammatory pathways are dysregulated. The concept of immunosuppression may encompass related terms such as immunotolerance, immunoparalysis, and or immunocompromise. We worry about is the persistence of primary infections, the development of secondary nosocomial infection, and sometimes the reactivations of latent virus. In these slides, we can observe the mechanism and the consequence of the immunosuppression. And on the innate immune systems, we observe reduced antigen presentations and impairment of the monocyte and dendritic cell functions. And for the adaptive side, we observe that there could be lymphocyte loss and also functional exhaustions. Here, we observe histological slides from the spleen of patients controlled and with sepsis, and we observe depletion of lymphocytes, both CD4 and also the CD8, and reduced expressions of HLA-DR. So that is very important. Davenport and colleagues performed and analyzed the genomic signature in sepsis, and they described two endotypes. The CERS1 endotype that is described as relative immunosuppressed with endotoxin tolerance, T-cell exhaustions, and also down-regulation of major histocompatibility complex, class 2, and was associated with higher mortality. On the other side, the CERS2 endotypes was relatively immunocompetent with lower mortality. Other transcriptomic signatures were described, mainly in the MARS and also in the Stanford database. And recently, Cycluna reported and transcriptomic clusters. They analyzed two big data sets, the MARS and also the GAIN in the UK. And they described these three endotypes. And they observed that these three endotypes have different severity and also different mortality. If we analyze the compartments of these regulations, we can observe that these regulations can be observed on the lymphoid compartment and also in the myeloid compartment. And those with both these regulations were those patients with higher severity. These are the result of one study we are performing in our hospitals. We are analyzing a commercial kit that reported the TNF-alpha release after the exposure to LPS. So we analyze the endotoxin tolerance, and we include patients admitted to emergency department with unsuspected infections and a new score higher than 3. And we observe that those patients with endotoxin tolerance were similar in terms of age and sex, the topic of this talk. No difference was observed in terms of comorbidity, and we observed difference in terms of the source of infections. Patients with endotoxin tolerance have more respiratory infection, instead those without tolerance to endotoxin have more urinary infections. 83% of the patients with endotoxin tolerance developed sepsis in the first 24 hours. Expression of monocyte of the HLA-DR are also associated with poor outcomes, mainly on day 3, and also is a marker for probability of ICU-acquired infections. The expression of the HLA-DR was associated also with higher ratio of neutrophils and lymphocytes. The lymphopenia is a common feature of sepsis. I show you here 2 studies, one performed in patients with COVID-19 and other in patients with hospital-acquired pneumonia. And we can observe that a very severe lymphopenia was associated with a lower survival probability. The most important here is to see that the risk is not directly proportional to lymphocyte count. So we must take into account when we analyze meta-analysis and also some score that implement the use of the lymphocyte counts for severity. The cause of lymphopenia is the decreases of lymphopoiesis, the increase of apoptosis, and also the traffic from of the lymphocyte from the blood to the tissues. As we say, the clinical outcomes are poor in patients with lymphopenia. There are several gaps and also potential future therapeutics, including EL7 and the inhibitor of PD-1. Two consequences of the immunosuppressions is the development of secondary infections, such as ventilatory-associated pneumonia. Here, the incidence of pneumonia in patients with COVID-19 was really high, and also the viral reactivation. Here, we can observe the poor outcomes that those patients with herpes virus reactivation. For the therapy, there are several potential targets. The inhibitor of PD-1 and also the EL7 are both drugs that was tested in small clinical trial. Further studies are required for evaluate the efficacy of these drugs in patients with immunosuppression. The interferon beta also reverse the immunosuppression. Here are the result of an in vivo study. And also the interferon gamma was evaluated in several studies. I will show you 2 clinical trials. This is the first one, the interferon gamma for the prevention of hospital-acquired pneumonia. This study was early discontinued by safety issues. We can observe here a trend for higher risk for those patients in the treatment arm. And this is the other one that evaluate precision immunotherapy for those patients with a macrophage activation-like syndrome were treated with anakinra, and those with an immunosuppression profile were treated with interferon gamma. In both arms, the author observed that improved organ dysfunction at day 9, and further study are required also for this strategy. As conclusion, we can say that sepsis-related immunosuppression is a feature of sepsis. Different transcriptomic signatures have been described. The lymphopenia, the decreased HLA-DR expressions in monocytes, and endotoxin tolerance can be used to diagnose an immunosuppressive state. And several treatments are being studied for the treatment of sepsis-related immunosuppression. Thank you very much. Thanks again for the invitation. I will be happy to answer your question. And if you want to discuss the results or any topic related with this talk, you can send me an email or follow us in LinkedIn. Thank you.
Thank you, Adrian, for your talk and your precise indications of the changes of the immune response in these patients with sepsis. May I ask you, what is the role of the microbiome in the immune response? Do we need to try to transplant, to do a transplant of fecal transplant in patients, especially for the long-term immunoparalysis in these patients?
Yes, that is a very interesting question. There are several gaps related with the interactions between the microbiome and the long-term outcome of the patients with sepsis. We know that the patients with sepsis developed dysbiosis, but there are not evidence of the efficacy of transplant of microbiota. There are some results in terms of those patients with colonizations of AMR bacteria, but we need more data. For sure that dysbiosis play an important role as a regulator of the immune functions, but we need more data for analysis. I think that not only the microbiome, also the interactions between the microbiome and the immune system. We must know how the immunoglobulins regulate the microbiome, and also the transplant of microbiota or other strategies could be useful for the long term of patients with sepsis.
Okay, so thank you very much, Adrian. And we need to move to the next presentation that will be done by Alison Fox-Robichaud. She is Professor of Critical Care Medicine at the McMaster University and Director of the Medical Education at the Hamilton Health Science. And she is the Scientific Director of Sepsis in Sepsis Canada, and chair the Canadian Sepsis Foundation. And her research spanned to preclinical sepsis model and biomarkers investigation and quality improvement to reduce the hospital-acquired sepsis. and Alison will present a talk on immune differences and responses to sepsis in women. So, is the immune system or the immune response different in women versus men? I'm sure that she will clarify this. Alison, it's your turn now.
Thank you. Oh, sorry, of course I have to cough. Good afternoon, good evening. Welcome everyone from around the world. I'm going to start by talking initially about some of the immunological sex differences in females versus males, particularly focusing on the innate immune response, and review the literature that exists, how females respond differently to infection and sepsis. And then maybe at the end, we can find some time to discuss how particular life experiences in women, such as pregnancy and menopause, may alter the host response to infection. I want to reflect on 3 women who are Canadians who we've lost due to sepsis at various stages of their life. The first was a mother of 3 child who died of group A strep after delivery of her 3rd child. We screened for group B strep. This woman died of group A. The second was an elderly woman who was in continuing care and died of a urinary tract infection, and her daughter told her story in the media. And the final one has been in our national media for the last 12 weeks. A young woman with opioid use disorder and indigeneity who was left to wait in a waiting room because they thought it was a social admission. And our coroner's hearing just concluded that we could have done a much better job. I also want to remind you that infection and this progress from infection to sepsis is complex. It involves multiple markers. It includes coagulation cascade, not only the immune response and the complex interaction of that eventually leads to intravascular thrombosis, endothelial injury, and tissue permeability in an effort initially to control that infection. Let's start with the first thing that we know. We know that healthy women have less circulating monocytes and natural killer cells and different immune phenotypes. So this study that was recently published in Frontiers of Immunology really characterized this in a large patient population and went on to do some subsequent mirroring work in this, which showed that women have less monocytes, less natural killer cells. And I want to focus particularly on the monocytes in these women. And I appreciate Dr. Ostermann separating that difference between sex and gender, and it does get complicated in here. And this authors clearly report the sex differences and not the gender differences. But I want to highlight a few things. The first is the differences. So the big positive means females make more of these than men. So interferon signaling, class 1 antigen presentation, which often leads to women having more autoimmune disease. But at the same time, less interleukin-6 signaling, less interleukin-1 signaling. In addition to that, there are inflammation regulatory genes that primarily get turned down in women compared to men, and other controllers. So you can think of the things that get ramped up in sepsis, and in fact, there's less of them being upregulated. And finally, 2 of our big cytokines, interleukin-1 beta, often response for some of the fever responses, and interleukin-8, important as a cytokine signaling to bring additional molecules in. The other thing is that although women may produce less monocytes, the monocytes that they do produce behave differently. In this paper, they talk about the fact that these monocytes have increased phagocytic capacity, and that these monocytes may in fact have more expression of CD64 on their surface. Why is that important? Well, CD64 links through the MHC molecule to make more interferon, and this may be one mechanism by which female monocytes have increased killing capacity, not only because they're more phagocytic, but in addition, because they downstream signal to CD4 T cells to produce more interferon. There are also sex differences known in neutrophils. We know that neutrophils from females also have higher phagocytic capacity, and neutrophils from females have lower toll receptor expression, which means they don't get ramped up as much in response to pathogens when they're exposed to them. And so that may mute the sepsis response that we're seeing. I love this figure that just came out from Journal of Leukocyte Biology that talks about over the years the impact in women with estrogen into menopause, but it highlights the fact that men may produce more reactive oxygen species, may have more migration. Maybe there's not a difference in the amount of netosis between the two of them, but neutrophils have more phagocytosis and better bacterial clearance over them. And this may or may not be related to hormonal effects, but it's an area of investigation. Now, there's a subset of neutrophils called low-density neutrophils, and these, in fact, in women may in fact be more immature. Some suggestion from mouse studies suggested immature low-density neutrophils may have a capacity to make more nets. That is, they release their DNA into the circulation that sets off the coagulation cascade and releases endonucleases and elastases into the circulation. And this figure highlights the fact that there is a different energy between neutrophils from men versus neutrophils for women that may tend to be more glycolytic and quiescent, and these immature neutrophils as well. Finally, women have survival benefit from sepsis, and I think we've talked a little bit about this. This is just two retrospectives, a small one from Egypt and a larger retrospective one from Germany that says even when you account for age, there appears to be a survival benefit for women over the ages, but particularly in older women, that's sustained despite the fact that these women are postmenopausal. So this really is an area of interest, and it didn't necessarily account for some of the comorbidities that people have discussed in the previous studies. The next slide is hot off the not yet published Canadian press, where we've actually looked at the Canadian incidence, excluding the province of Quebec, but show that the rate is different between men and women across Canada and over the years, with a significant increase, particularly peri-pandemic, but that is also associated with less mortality in these women, adult women, over that same time period. More data will be coming on this. And finally, the pathogen may in fact have some impact on mortality. These are two large systematic reviews from the same group. They began by looking at the age-adjusted mortality in female versus male patients in a large number of published studies. You can see it ranges from about 2018 to 2020s. And the long and the short of it is they found, with still significant heterogeneity between these observational studies, an 18% increased risk in mortality for women with Staph aureus bloodstream infections. But the same group was unable to show, when they appropriately adjusted for confounders, that the same thing occurred with gram-negative bloodstream infections, suggesting the pathogen may in fact have some impact on this ability to react. And Staph aureus, being the nasty bacteria that it is and can evade nets and other things, may depend on some of those mechanisms that are somewhat suppressed in women. So in conclusion, I'll start by saying sex differences exist in the immune phenotype of cells involved in the innate immune response, and I don't think we fully understand some of the T cell responses that may lead to immunosuppression as well, but this immune response extends into pathogen responses. in general, women may have an immunological advantage to be protected from developing sepsis. This is seen in population-based studies from multiple countries, but this may not extend to certain pathogens or extend to postmenopausal women, and we don't understand that. The interesting shift about elderly women and the infection shift from urinary tract infections from pneumonias is an important area to investigate. I want to highlight the fact that this is really a needed area of research to determine if different treatment strategies should be applied to women who do become septic, and whether this is impacted on life cycle changes specific to women, such as pregnancy and menopause. And with that, I'll stop sharing.
Thank you very much, Alison, for your very interesting presentation. I have just two quick questions. One is, you mentioned that the pathogen seems to play a key role, and the next question is also related to the source of infection. Is the same for pulmonary infection or urinary tract infection or gynecologic infections or candidas, etc.?
It's a very important question. I don't think it's been investigated. These are really the only two big studies that I've found that have sorted out the sex differences between the site of infection or the source of the pathogen. And I think it's a ripe area for investigation to really look at, are there differences? I mean, we know that anatomically women may be more susceptible to urinary tract infections than men. But is that because, are we protected because we carry a different microbiome in that area? And so there's a relative balance in all of that as well.
And the second question is, you mentioned that they are producing more interferon gamma as a host immune response. Do we need in those patients that they have a phenotype with a hyperinflammatory response to modulate this with a monoclonal antibody, for example?
I suggest it's an advantage, not a disadvantage, to make that interferon gamma. I think that they're using that transition from innate to adaptive immunity to actually enhance. And it may be that women have that advantage to be able to kill the bacteria before you get the dysregulated host response to that infection.
And these changes in the immune response is also transferred to the baby in pregnant ladies?
Well, and again, we know that women, yeah, again, it's an important, we know that women in general have a different, and I didn't have enough time to go into that literature about how women are protected, but we also know it's harder sometimes to find infections in women. And then once they've delivered, it's clear they're at equal risk, or around the peripartum area, they're at equal risk for developing severe infections. But it's interesting, the stories that you hear are all related to often gram-positive infections particularly. So I think that's a ripe area for investigation in the peripartum area.
Okay, so thank you very much, Alison, and we move to the last presentation that will be done by Vanessa Lanziotti. Vanessa is a pediatrician and especially on intensive care, in pediatric intensive care. She is a professor of the maternal child health postgraduate program at the Federal University of Rio de Janeiro. And she's Chief of Research and Health Technology Innovation Unit of the Pediatric Institute in Brazil, and a member of the Latin American Sepsis Institute board. So Vanessa, is your time now.
Thank you, Antonio. Good afternoon, everyone from Rio. It's a sunny afternoon today. And I would like to thank the organizing committee for the invitation to speak today. And I'm going to talk about the importance of biological variables in sepsis in children. So this is my agenda for today. I have no conflict of interest regarding this presentation, except for being a mother and a passionate pediatric intensive care doctor that is interested in improving the outcomes of our children worldwide. So pediatric sepsis causes more than 3 million deaths annually worldwide and remains the leading cause of childhood mortality and PEDS ICU admission. And this burden is even higher in the countries of the South Global. And why biological variables matter in pediatric sepsis? We know that infection is dependent of many factors, including the host, the profile of the host, and the response of the host to the treatment that we do. So sepsis is not a uniform syndrome, it's a heterogeneous syndrome. And for this, in sepsis, definitely one size does not fit all. So in children, outcomes are profoundly shaped by host biology: age, sex, development stage, immune maturity. And understanding these variables is essential to moving beyond one-size-fits-all treatment to a precision critical care treatment. So what are the key biological variables in septic children? First of all, development age. Children are a biologically dynamic population. We treat from newborns to 18 years old teenager. It's a huge variation. Second, the biological sex. Hormonal and genetic factors contribute to different inflammatory phenotypes, as was already presented by great lectures before. And host genomics and biomarkers who are crucial for stratification and the path to precision medicine. The fourth is the microbiome and comorbidities. And in children, we know that these chronic conditions and the developing microbiome can influence the course of sepsis, yet these factors remain underrepresented in adult evidence. So on this lecture, I'm going to focus on these three first ones because we have a limited time. And we are going to start with the developmental age. Pediatric immune system is not simply a scaled-down version of the adult immune system. We know that there are age-related difference in the immune response to pediatric sepsis that is different from newborn to adolescents, almost adults. And we know also that patients under 1 year old are the ones with higher risk for sepsis. Also, there are physiological differences regarding hemodynamic response to infection, microcirculation in sepsis, and drug metabolism in different ages. And this pediatric sepsis assessment requires age-stratified approach. Age, we know nowadays, that influence treatment. And this is so important that age-stratified approaches were included in the Phoenix criteria on the last international consensus criteria for pediatric sepsis and septic shock published 2 years ago. What about biological sex? As was already told, hormonal and genetic factors contribute to distinct inflammatory phenotypes. In pediatric patients, the sex-linked difference in innate and adaptive immunity influence not only the susceptibility of the patients, but also the outcomes of the patients. Male sex in general, especially in early childhood, is associated with higher incidence and greater severity of sepsis, and there is not so much confounding bias as we have in adults. And females demonstrate a stronger innate immune response with elevated cytokine production. And what about host genomic and biomarkers? This is maybe the most important regarding risk stratification and the path to personalized treatment. Why? Because we know that clinical judgment is still insufficient to an early identification of outcomes. Biomarkers and precision medicine are promising for improving outcomes and new target therapies, and these include not only phenotypes, but also endotypes. And how is this stratification in critical care? We have the big phenotypes with the main syndromes as sepsis and ARDS, for example. We have then the subphenotypes that include variables in clinical manifestation, biomarkers, and the response to the treatment, and the endotypes that are molecular signatures for each host. And this stratification can help in the target treatment considering variable biological rationale. So sepsis stratification has been studied a lot, especially on the last decades, and we have many studies published regarding these aspects. And we know that risk stratification strategy involving multiple biomarkers may be required. I'm not going to enter very deeply on this aspect right now because we have no time for that, but we have to remember that what's the role of biomarker is to personalize the therapy in a path to precision treatments in the pediatric patients. So what about the host genomics and biomarkers considering the machine learned models that we have available today? We have these possibilities of machine learning models with multiple biological variables that have been studied, aiming not only guide selections of therapies, but also stratification, thinking about a special treatment and better outcomes for the children. So this is a study published by the group of Professor Carcillo from the University of Pittsburgh, and they developed PET sepsis phenotype calculator, including not only clinical variables, but also biomarkers that are usually available at the bedside, like CRP, PCT, ferritin. You can open this and you can use it. And this calculator has been validated in many cohorts worldwide, including Latin America. And the biomarkers at the bedside. This is really important nowadays. The use of biomarkers in pediatric sepsis include screening and diagnosis, treatment response evaluation, rational use of antibiotics, and stratifications. What are the most used biomarkers nowadays? The CRP, the C-reactive protein, and the procalcitonin. Also, the lactate has been used a lot in not only in response evaluation, but also for the prognosis of outcomes in patients. And it's so important that was included in the Phoenix criteria as well. The lactate has been studied on the last decade as a prognostic biomarker. We see that there is an association between early lactate levels and outcomes. Higher is the levels in lactate at the admissions, higher are the hospital admission, PICU admission, invasive treatments, and worse outcomes. And this was really recommended since the last consensus of sepsis in 2020, when they suggest that we should use the trends in blood lactates in addition to clinical assessment. And on this last recommendation this year, published last month, this recommendation was incorporated, and for children with probable sepsis or suspected child sepsis shock, it was recommended that the blood lactate was part of the initial assessment of the patients. And what about PCT and CRP? Procalcitonin has been using a lot on the last years, but with not much strong evidence. So the last recommendation in sepsis guidelines for pediatric patients is not using procalcitonin routinely to guide de-escalation therapy when effective antimicrobial stewardship programs are in place, so not routinely used. And CRP test, that is the older biomarker, very available worldwide, low cost, easy interpretation. We published this cohort, this Brazilian multicenter cohort a few years ago, that showed that despite being non-specific, when used dynamically, its dynamic evaluation can be used as a predictor biomarker with good correlation with not only organ dysfunction, but also with outcomes in pediatric patients. These results were also showed before in adult patients. And last but not least, biomarkers and endotyping. That is the real deal, the real path to precision medicine. We have known that transcriptomic and proteomic studies show that septic children can be grouped into biologically distinct endotypes, like molecular signatures, and translating these findings into actionable clinical tools remains the central challenge to the path to target biological therapies. So we have still a long way to go, but I think we are on the right way. And what are the key messages for these lectures? Biological variables remain essential for pediatric sepsis diagnosis and management, but their interpretation must account for, 1, age-specific developmental difference, not only because of the immune system, but also the physiological difference that we have between neonates, early childhood, and adolescents that work almost as adults. The biological sex-based variation in inflammatory response, the superiority of multiple biomarkers used together and machine learned models, including clinical variables with biomarkers over the use of single biomarkers, and the integration with clinical assessment and organ dysfunction scoring systems. What are the perspectives that are already being at the present and are the future directions? We should design clinical trials with enrichment strategy, with using predefined biological subgroups being phenotypes or endotypes, and integrate at the bedside. Develop clinical decision support tools that incorporate biological variables into real-time risk stratification and therapy selection, that we should do it for getting better outcomes. And we should never forget, clinical judgment remains essentials. So all these biomarkers are tools and very important tools for treating the patient, but they have to be used as tools, not substitutes for clinical judgment. So I would like to thank you, everyone, and I'm open to the questions that you may have.
Thank you very much, Vanessa, for your presentation. There is a question that I would like to ask to you, because as you mentioned, clinical information is always a key, very important. But patients, the same as in physiological information, are not static. I mean, are changing along the time. So do you recommend to monitorize the different biological variables that you mentioned in order that to identify if the endotype or the subphenotype is changing after 2 or 3 days of treatment, for example?
Yeah, one of the key messages from the last consensus in pediatric sepsis that was released on last March was exactly the needing of reassessment the patient, not only in a clinical way, but also lab way or biomarkers way. So we have to see how the patients evolve. So we gotta reevaluate not only the clinics, but also the biomarkers. For example, in the resuscitation, the trends of lactates are very important. Some biomarkers that are very available at the bedside, for example, the C-reactive protein. We did this multi-center Brazilian cohort using the CRP at the bedside on the first week of response to the antibiotics, and we saw that the non-response of the decrease of CRP was present even before the clinical issues. So we know that clinical judgment becomes more inspecific during evaluation of the first week or during the admission of the patient. So we definitely have to do this to evaluate that dynamically, using, of course, all the things that we have. Nowadays, we have so much stuff to do at the bedside for the patients, POCUS and the echo at the bedside, and even the biomarkers. And I think since we are having exponential growth of the discoveries in molecular and biological science nowadays, probably in a decade, we are gonna laugh about what we are saying today. Probably we are gonna see biomarkers being used with a little, a blood sample, for example, to figure out the signature of molecular signature of patients. So I'm very optimistic and believer in the clinical variables and the biological variables for better outcomes in the patients. I don't know if I answer your question.
Yeah, absolutely. I buy your wish, your future wishes. But probably in the future it would be necessary to the same as it has been done with physiological parameters, to move to the biological monitoring continuously in these patients, to have close information of the changes from biological point of view, and not only on physiological point of view.
Thing for sure, and I think in pediatric is harder because you have such a wide range of patients, right? You have like newborn that are not small infants and infants that are not small adults. So these biological variables are also very distinct from this population, not only the physiological ones, but I think these two groups together, clinical plus biological markers and biological variables, are so important to figure out and to improve the treatment in a way that we got better outcomes.
Okay, so thank you very much. I think we need to finish this session because our time is finished. And I would like to thank all the speakers for the excellent presentation. I hope that this will be very useful for the participants in this Congress to give new information and to help them for the future studies to try to improve the management of patients with sepsis. So thank you very much for all of you, and
thank you.
Bye.
Bye-bye.